Hello to everybody. My name is Christian Vincent, and I'm actually in charge of the clinical program at FEOPS. It's an honor and a pleasure to present that education session. FEOPS is engaged in education with a focus on meet the expert on digital health. And today the session will be focused on please, Peter, can I have the next slide? On the complex TAVI intervention with ACURATE neo intervention. It's really an honor and a nice thing to have Professor Peter Jaegere from the Erasmus Rotterdam Hospital in the Netherlands. So the session is planned for a 30-minute session, including discussion. So that's very important to know that the methodology is a very interactive session. So for the interactivity, you have two possibilities. One will be the quick polls. Professor Jaegere will ask you a couple of questions, so it's very important that you can answer those questions, and Professor Jaegere will comment on the results. The second way of having interaction is to go to the chat line below your screen. You can click on the chat and you can ask any question. I will regroup those questions and asking those questions to Professor Jaegere at the correct timing. So by saying so, I just want to show the last slide of my introduction, which are what are the learning objectives. At this Meet the Expert, you will benefit for a unique occasion to comment, question, and exchange with your peers. So really at the end of this module, you could potentially identify challenges in complex TAVI intervention, such as the BAV cases, when you use an ACURATE neo. Also understanding the role of patient-specific virtual implants in different morphologies, explore all the functionalities of FEOPS Heart Guide pre-operative planning tools, and at least, and last but not least, participate in a case-based discussion that highlight the clinical value of advanced pre-operative planning. By those words, I wish you a very fantastic PCR course, and Professor Jaegere, the word is yours. Thank you so much. Peter, you are mute. Peter, you unmute. You still need to unmute you first.
My apologies.
Nice.
I was thanking Christian for the introduction, and I would like to welcome you at this session organized by FEOPS. For your information, my connection with FEOPS is of a pure academic, intellectual one. We had the honor and pleasure of working with FEOPS for the last 10 years, and in particular, doing the validation studies, validating the software the engineers of FEOPS have developed, and of course our role was the clinical role in which we define the problem and also define our clinical needs. Having said that, so I have a sort of a track record of 10 years with FEOPS. What I would love to do with you this morning is to present the patient to you, and thereby illustrating in what way this technology may help you. The patient concerns an 83-year-old female patient. She was referred to us from elsewhere because she was rejected for bypass surgery, single vessel disease in combination with SAVR, surgical aortic valve replacement, because she had repetitive urinary tract infections. It concerns a very vital 83-year-old patient. She was an active swimmer, no antecedents, physical exam, nothing special, completely independent. ECG, sinus rhythm with this left bundle branch block, I would say a little bit a nasty left bundle branch block. This is the echo. These are still frames for reasons of convenience. For your information, in our institution, we have 3 TAVI operators, structural heart interventionalists. We do see, as a group, all the patients ourselves. And I never read the reports. I look at the images myself. And again, these are still frames, but what I want to show you is the left ventricle, the morphology. You clearly see the hypertrophy, left diastole, right systole. So she has a normal systolic function, moderate diastolic dysfunction unexpectedly, and she has a hugely dilated left atrium. But of course, the focus is on the aortic valve. She has an antegrade velocity of close to 6 meters per second. However, you have to consider the aortic regurg. She has a pressure half time of 223, so she has a moderate to severe aortic regurgitation. This is the CT and our Tremensio software analysis. We do all the analyses ourselves. You see the 3 levels: above the annulus, at the level of the annulus, and a bit below the annulus and the LVOT. And we were struck by the huge amount of calcification. So we went back to the raw data themselves, to the CT, and on your left side, you see the cross-sectional view of the tricuspid aortic valve with a huge amount of calcification on the left leaflet in front of the ostium of the left coronary artery. And the imaging specialist said to me, Peter, you simply cannot do the TAVI procedure because you're going to block the left coronary artery. So that was a problem. We went back to the angiogram that we received from the referring institution. You see that U-shaped calcification of the mitral valvulus, but the arrow is indicating to the bulk of calcium sitting in the left leaflet of the aortic valve, and you see the spatial relationship with the non-coronary sinus. It's a still frame, but if you see the movements, well, you can imagine the movement. So that is the patient I present to you and that I would like to discuss with you and also have your input. How would you proceed with this patient? Before doing that, there's one question that we would like to address to you, and these are those. This is the question: what would be your further planning or decision in this patient? You would say TAVI is not possible because you're going to block the coronary artery, or secondly, would you go for TAVI based on the available information, just like that, or do you say, well, I consider, but I would do additional investigations such as patient-specific computer simulation? So we would like to have your opinion on that. Okay, oh, so the job is done. We can close the meeting. Well, that's exactly what we did. I continue with, I can close this here, I see, yes. So, I'm happy, so there's a little discussion. So what is patient-specific computer simulation about? At variance with what some people do and propose, this is not geometric fitting. This is not superposition of a device on an image. No, it is true assessment of the interaction of the device with the host. What is it that these engineers need from us? First of all, we need to deliver a patient-specific anatomy derived from CT. That's a digitalized information that they can process and work with. But you also need to have what I call the anatomy of the valve. And I can go into detail how that has been done, but you need those details of the two objects, so to speak. But that's not sufficient. It's not only about anatomy, you also have to know how they behave in terms of a mechanical behavior. So you need to know the mechanical properties of both the device and the host. The device is easy. You can do stress strain and in vitro simulations. And so you know how the valve, the frame, or the tissue, or the frame itself will react upon a certain stress-strain relationship. For the tissue of the patient, you can't cut away the tissue of the patient. However, there's experimental data, and you can introduce a certain number of assumptions. What we have done in those 10 years with the engineers of FEOPS, they have constructed the algorithm, assessing the interaction of the device of the host based on the principles I just explained. And then we did a number of CTs post. And these were the validation studies based on what was predicted and has been observed. The engineers trained and improved the model. This has all been published. And then comes, what is the question that you want to know? Well, you want to know what will the frame look like? What will be the degree of apposition? With the addition of computational fluid dynamics, you can detect and quantify the amount of eventual PVO. And when you enter contact pressure, you can assess, quantify the contact pressure in the recipient anatomy that can be used for the prediction of eventual conduction abnormalities. And this is summarized on the next, oh, sorry, this I thought it would be another slide. I will show you the report that you as a user would receive from FEOPS. I will run the video in a second, but that's the starting frame. So please know it's quite interactive. You can tilt, you can rotate, you will see it in a second. This is the baseline anatomy. And there are a number of functions. You can click on the function buttons where you can see what will be the final result. We ask for an ACURATE valve. They follow the sizing matrix provided by the manufacturers. And then you can assess what will be the frame geometry, their position. If you add the PVL function mode, you will see and quantify the quantification of the PVL, and the same holds for contact pressure. I will show you that by just running the video. So this is an example of what you can do. This is, you push the button of the final result, you rotate, you look at it, you can magnify as you see, you can play as much as you want with this, and then you will see that the user here will activate a number of function buttons. This is the contact pressure. The color intensity is a reflection of the severity. This was the apposition. And by the way, this is the computational fluid dynamics. And on the right-hand side, you see the exact numbers. So in this patient, with this ACURATE 23, you would have a PVL at that level of depth of implantation. And by the way, they do simulations for 3 depths of implantation. For the ACURATE, it's not that needed because it's almost standard, but this patient would end up with a PVL of 10.4 millimeters per second. However, I'm going to, this is a repetition, and my apologies. So that is in summary, the outcome measures that you have received. However, what was a problem in this patient, our concern was not so much the PVL or the contact pressure. And by the way, with the ACURATE valve, it's a very low likelihood of ending up with conduction abnormality. So that's not the issue. The issue in this patient was this problem, what I showed on you, what I showed on the left-hand side. And this is on the right-hand side is the 3D display of what the engineers in FEOPS have engineered. And you see how closely, at least in this image, the amount of calcium that is sitting here in front of, this is a left coronary artery, is really matching with what has been seen in vivo from CT. Because we were still in a concern, the image is nice, but then we asked the engineers, well, I want to see it. How will the ACURATE valve act really while deploying? And I'm going to show you this in this video. This is the actual deployment during simulation of the valve. It goes a bit quick. Here's the amount of calcium sitting in front of the left coronary artery. So with this information, we felt reassured. We will perform a TAVI. But still there was discussion. So we went back to the simulation, and these are still frames, but we did quite a number of analysis ourselves on that simulation process. We started because we wanted to be absolutely sure that this is feasible to do. This is, again, a view that we selected. You see the nadir of the 3 sinuses, and we were focused on that calcium in relation to the left coronary artery. This is the picture after ACURATE valve implantation, was at 23. Okay, it's sitting there. We have no information. We have the spatial relationship here. We don't have the flow in this picture. We tilt it a bit and we continue. Okay, that seems to be reassuring. No obstruction there. We continue. That you have seen that cross-sectional view. This is after valve implantation. Again, this is the calcium, this is left coronary artery. So the calcium is somewhere squeezed here, but there seems to be patency of the left coronary artery. And you can make zillions of those pictures. And again, we did this because we want to be absolutely sure that this would be a feasible procedure and a safe procedure. And this is again another picture that seems to be reassuring. Another one, again, and this is a bit disturbing. You see that we were turning into a loop. The cross-sectional view we have seen. And what we did then is we asked the engineers, well, give us the video which you or we can rotate the video itself. Again, having a look again and assessing, focusing on the spatial relationship of that calcium node in relation to the left coronary artery. So that is the case that I present to you, and then in which we have done a simulation. So with this information that you received from me and this particular patient, we were wondering, having this insight now, what would be your practice in your hospital when you face an anatomy that you don't feel comfortable with? As for instance, in this case, which is quite a rare case with such an amount of calcium in the left leadlet. Would you still go for TAVI based on CT according to the routine practice? Would you go for TAVI according to the practice CT, of course, based with computer simulation, or other ones? Or do you have another proposal? And I do realize, as 100% of you have already at baseline selected for simulation, so I'm wondering whether there will be other opinions in the audience. We're looking forward to your answer. Okay, that is interesting. The conclusion here is I did an extremely bad job, because 25% now go for TAVI using regular practice, while at the outset everybody was convinced. So that is not a good thing from my side.
Professor Jaegere,
yeah.
Here. I think that there is one question coming to my private chat. The question from the audience is, didn't know what to vote because I don't know exactly what time it takes to get the result from the computational modeling, based on the fact that sometimes I read it based on the fact that on preoperative planning, time is important conditions to access the computational modeling, yes or no?
Yeah, I believe, Christian, you are better positioned to answer that question. Yeah. I have the time delay, and it is quite short. If you have a patient today, you upload it today, you will have the result. And please correct me if I'm wrong, even this evening. But please, you have the current numbers. Yeah,
the real. So thank you, Peter, for that. The real answer for that is indeed. Normally, we take up to 48 hours. That's the standard procedures. But indeed, if there is some urgency, we can decrease to somewhere closer to 1 day. Less than that will be challenging. But normally, the standard opinion about that is 8 hours. This is the time around time.
Okay. So thank you for the correction. So 1 day. That leads to the next question that we can discuss. Is it sufficient? Should it be shortened? Is it feasible to shorten this? I don't know. I do know technically the processing with artificial intelligence in terms of segmentation and landmark detection, that takes you less than a second, but still you have to upload the CT, they have to process the CT. So there's one responsibility of, let's say, the engineers and FEOPS to make it quicker. The question is, do we need this? I can imagine that in certain patients, yes, because you want to have a quick answer. On the other hand, the majority of TAVI patients are all elective patients. We rarely, if never, do an urgent TAVI, but that's open for discussion. I do not know whether anyone wants to react on that via the chat. In the meantime,
no further comment. No further comment.
Okay. So in our institution, and this is also my opinion, and we have to be honest, do we need to do that in every single patient? I don't think so. However, we're expanding the indications. We think of the surgical candidate, so we will see more patients. We will see patients with more funny anatomy, most likely. What we believe is certainly a reason to prepare better and using computer simulation is this menu that you see on the left-hand side. Once we had a patient with a very flat sinus, it's not that, well, it's even rare. What we do often see is patients with low coronary implants. That is certainly an indication to do a bit more pre-TAVI workup for reasons of the risk of coronary occlusion. What we consider an indication is severe ellipticity of the annulus, with or without severe calcification of the annulus. Then we come to the valve itself. The present patient is a nice illustration, I believe, thereof, a severe calcification of the leaflets. And of course, the bicuspid aortic valve, which is not uncommon, even quite frequent, functional and the true anatomic bicuspid. And we recently had a patient from a Chinese colleague in whom we did simulation with a quadricusp valve. And then if you go upstream towards the LVOT, I believe that we should look more carefully to the LVOT as well. You may see mostly it widens up, but you have patients where it narrows down, a funneling of the LVOT. There I have a true concern of inducing conduction abnormalities. That leads me to the location of the membranous septum. We have respect for work of other colleagues where they measure the distance from the annulus to a certain spot of the inferior border of the membranous septum. We have to acknowledge this is a 3D structure and a complex 3D anatomy. And we know from experience of all those simulations, and this is work mainly done by Giorgia Rocatello, that the inferior border of the membranous septum may cross the annular plane. So again, with all respect for what people propose, that's two-dimensional measure the distance of the annulus to a certain spot of the membranous septum, I favor to look at in a more 3D way, given the complexity and the variation of anatomy. And we have to, if there's something that we need to beat, of course, we need to beat a number of things, such as the vascular complications, but also the conduction abnormalities. And of course, another reason to consider more advanced planning if you have calcification or a certain degree of calcification of the left ventricular outflow tract. I believe that I come to the last slide now, that we have called facts and conclusions. What are the facts? What is our medical responsibility that we have as physicians? Well, it's clear TAVI is increasingly being used as a default treatment of aortic stenosis, supplanting surgical aortic valve replacement. And very recently, November the 13th, so a couple of weeks ago, we had a European proctor meeting. And the main focus of that meeting was, that was not on the agenda, but it was focused on sizing. And one colleague said, we do not know how to size. And I believe that he's making a point. So we still have discussion how to size properly. There's a sizing matrix, but of course you and I know it's much more complex. And on top of that, the authorities demand us cost reduction and advocate precision medicine. So therefore, of course, I have that intellectual connection of the last 10 years with the engineers and the team of FEOPS. But as the program will continue to increase, moving to the surgical patients, I think that our responsibility is to select patients for more advanced planning before a TAVI procedure. And in particular, with, as you have heard me, I don't favor geometric fitting. We have to assess the interaction of the device with the host. In other words, patient-specific computer simulation to enhance the safety of the procedure. And I hope, and again, I feel sorry that I didn't do a good job, that this case is an illustration thereof. And by the way, this patient has been treated successfully. Patient-specific computer simulation also helps you by predicting the interaction of device and host, the valve performance. Think of PVL, think of conduction abnormalities. So we have the tool to select a valve that best fits the individual patient. Think of the precision medicine. And as we have recently demonstrated in an European prospective cohort study, that the simulation that impacts on the pre-operative procedure planning plus procedural execution. What we found in the TAVI guide study that was recently published, that operators try to achieve a depth of implantation to avoid conduction abnormalities. They had a plan beforehand, and they try to achieve that depth of implantation during the procedure. And we do have technologies now that allows us to much better control the depth of implantation. Unfortunately, the Lotus valve disappeared from the portfolio, but with the ACURATE, the degree of precision, basically you don't have a choice. You have to implant it at a certain depth of implantation, so you know where you're going to end up. I believe this is it for this presentation. I return the micro to Christian. It's a bit funny. We're doing it all in augmented reality. But I would love to discuss this further with you. And I would certainly love to know your opinion. I have an opinion, but you have opinions yourself. And if there's time to discuss, Christian, I return the micro to you.
Super, thank you. Can you go to the last slide, Peter, please?
Oh, I'm sorry.
Yeah, no, yeah. So thank you so much. First of all, I really want to thank you, Professor Jaegere, for this outstanding presentation, looking at one of the possibility indeed of using FEOPS hard guide into the preoperative planning. I like this case, and indeed going probably to the complex anatomies and cases is clearly the way to go. Thank you for clarifying that to all of us. For the audience, thank you for being with us today. I also would like to invite you to discover a little bit more during this PCR convention, London Valve. It's a big session. So you can see we will have an education group, the one that you can see on the screen here, where you can find a lot of resources, additional things, all the publication that has been done. You can find videos. And last but not least, there will be additional education session. For example, the next one is today at 2:00 p.m., which will be focused on the use of FEOPS hard guide on the LAA closure, with a focus on the Abbott Amulet device. And after that, we will have other possibilities on education still today, and also, of course, tomorrow for the TMVR access. So by saying that, I wish you all a splendid PCR this year. And again, Professor Jaegere, thank you so much for your presentation today. So I wish you a great PCR London Valve. Thank you.